We'll introduce our featured faculty member today, Dr. Denis Nash. He directs the CUNY Institute of Implementation Science and Population Health. It's nice and easy to have that right in front of us. And is a professor at CUNY, one of the co-leads of their CFAR up in New York, and really a great thought leader in the implementation science and epidemiology space. And we're really grateful to have you with us. Denis is one of the original mentors of the program and has stuck with us all this time. So thank you for that, Denis. And we'll turn it over to you. Your slides look perfect.
Thanks for having me. I did have some updated slides that I can present today. So I wanted to focus on today on implementation outcomes used in implementation research and draw on some examples from our work within the IDEA collaboration. As an outline, I'll just talk about some of the different types of outcomes that can be used in implementation science research, and then a little bit about considerations for choosing some of these outcomes. I mean, not all outcomes are created equal, and what we measure can really influence what we can conclude about whether a strategy is effective or not. And then I'll talk about some specific examples listed here from the IDEA collaboration, which I think is there's a lot of research around implementation happening there. So this slide is sort of setting the stage a little bit. I know that you've probably heard different speakers talk about implementation science. And so I just thought I would set this up a little bit from my perspective. And so, we think of IS focusing on bridging the gap between interventions that we know work and those that are shown to be effective in more controlled research settings, and their adoption into routine service settings or routine real world settings. And so how do we ensure that we're focused on how we ensure that these proven interventions actually reach and benefit the populations that need them most. Once we know an intervention can lead to better health outcomes, IS can be used for studying the how and the why, how these interventions can be adopted, implemented, and sustained in different settings, and why they work or don't work. A central aspect of IS, in my opinion, is the use of strategies to introduce or modify evidence-based interventions within specific contexts. And there's a great paper, which you've probably seen, that is outlined some of these issues by Proctor and colleagues from 2009. But to do this work effectively, we need to be deliberate about the strategies we choose, and we need to test them for their effectiveness at implementation. The ultimate goal is really about learning how to improve the uptake of interventions and to enhance the potential for scaling them up across settings that are diverse and maximizing both their impact and their sustainability. So IS focuses on research questions that are related to implementation of a program, a service, a policy, or an intervention strategy. And this is a slide based on a framework that by Peters that lists some of the key considerations that can help us distinguish implementation science research from other types of research or from program evaluation, and includes things like, does the research clearly aim to answer an implementation question? Is the primary audience for research identified, and how the results will be used is essential for designing studies that lead to actionable insights. And then some things about it has to be clear on what's being implemented, whether it's a practice, a policy, or an intervention. Does it involve an intervention strategy? Is it in a real world context? And I guess for this talk, like, are the implementation outcomes, and we'll talk a little bit more about these in a bit, such as acceptability or adoption or fidelity, are these things appropriately considered in the study, in the research question? And so these are I find this list useful in thinking, and even sometimes in generating research questions. So Implementation research usually has outcomes that are conceptually distinct from the health outcomes that we often examine in health research, such as those typical outcomes include things like the presence of a health condition like hypertension, or the presence of or the onset of a new infection or a hospitalization or a death. Um, and implementation outcomes focus more on the effects of deliberate actions that we take to adopt and deliver new treatments, practices, or services. And these outcomes can serve as indicators of whether an implementation strategy has occurred or succeeded or failed. Um, they're considered more proximal indicators than health outcomes because they they directly reflect the processes that we're trying to influence with our strategies. So, for example, things like how well an intervention is adopted or how consistently it's delivered. Um, and importantly, these are intermediate outcomes that are prerequisites to improving the broader health outcomes through implementation of the evidence-based strategies that we're implementing. Examining them can provide crucial information on the pathways to achieving impacts that are more downstream, like the health outcomes we're interested in. And by examining implementation outcomes, we're also trying to understand the how and why of intervention success or failure in real world settings. So this slide outlines the three types of outcomes we commonly look at in implementation research: implementation outcomes, service outcomes, and client outcomes. Another paper from Proctor et al. The implementation outcomes reflect the success or failure of the strategies we use to deliver interventions, and they include factors such as acceptability, adoption, feasibility, um, sustainability, and they give us insight to how well an intervention is being implemented in a specific setting. And the service outcomes focus on how well health services are delivered, and these include measures like efficiency and safety and equity, patient-centeredness. And the client outcomes, sometimes referred to as patient outcomes, focus on how individuals experience and respond to interventions, and includes things like patient satisfaction or client satisfaction, functional improvement, and symptom reduction. And finally, when we look at health outcomes, we're examining like the ultimate goals of our interventions. For HIV research, these can include things like ART adherence or viral suppression or resistance to ART and survival. But by considering all three types of outcomes, we can get a more full picture of how successful an intervention is, from the intervention delivery itself to how it impacts health and service quality. So this table presents some implementation outcomes, and the key implementation outcomes we're considering, and their definitions based on the Peters paper I referred to earlier there. And in many cases, like the understanding these outcomes, these types of outcomes is crucial for evaluating how well interventions and the strategies that we use to deliver them are implemented in real world settings. So we have things like acceptability, which refers to how stakeholders or consumers or providers or policymakers perceive the intervention as acceptable or not, and of course this can influence the uptake of the strategy. Adoption captures the intention or decision to deploy or start implementing an intervention. And it tells us whether organizations, providers, or people are willing to even try it, willing to even try to implement it. Appropriateness looks at how well the intervention fits within a particular setting or addresses a particular problem, and it reflects relevance to the population and context. Um, Feasibility is about the degree to which an intervention can actually be carried out within the organization or setting, factoring in things like the resources, the time and infrastructure that are available to implement it and sustain it. Um, Fidelity focuses on whether the intervention was delivered as intended, adhering to the original protocol or plan that was set out. And it's key for understanding variations in outcomes and variations in effectiveness. Implementation cost can address the financial side of things, like how much it costs to deliver the intervention. Coverage measures whether the population that's supposed to benefit from the intervention is actually receiving it, engaging in it, and the critical step. It's a critical step for driving the reach of the intervention and its ultimate impact. Um, and finally, sustainability is about whether the intervention can be maintained or institutionalized within the setting after its initial implementation. So by measuring and analyzing these outcomes, we can get a more complete picture of whether and how well an intervention is being implemented and identify ways to improve its uptake and reach. So what drives the choice of outcomes in implementation research then? I mean, there are often several considerations. The most obvious choice of outcomes is the research question, and that should be driven, a choice of outcomes should always be driven by the research question. So what exactly do you need to measure or evaluate in terms of the implementation process? Are we most interested in adoption? Are we most interested in fidelity or sustainability? And second, the availability of data and the data sources. These often determine which outcomes we can feasibly measure. And so are there existing data sets we can tap or leverage? Do we need to collect new data? And the features of the implementation strategy also matter, as well as like the level at which the intervention is being implemented. So whether it's at the provider level or the site level or the community level, different levels of implementation obviously might require does require different outcome measures. And we also rely heavily on the implementation science conceptual frameworks that you may already have been introduced to or not formally in the course, but things like REAIM or CFER, and these can help guide the course of outcomes to help them align better with the broader research questions and the goals of the study. Yeah, and finally, there might be some context-specific considerations, including understanding the particular setting of the study, the population that's being served, and other practical considerations that might influence the success or failure of implementation. And I've included a table here from one of our team's HIV implementation research studies that when we write a grant and that's focused on implementation outcomes or that's focused on an implementation research question, we try to break it down, sometimes only for ourselves, but sometimes we actually drop this in, something like this into the grant. We break it down by the source of data, the type of implementation science construct, and the aim of the research. We're linking it here, we're mapping it to our conceptual framework, and or in this case we had two conceptual frameworks, and it just illustrates how you can, map various data sources and constructs to implementation outcomes like fidelity, timeliness, and service, timeliness of service, and sustainability in this case. So related to measuring outcomes in implementation research, to accurately measure implementation strategies, it's essential that we clearly and systematically define and specify them when we develop, deploy, and study them, right? So in this slide, I'm trying to highlight something from another Proctor paper that talks about best practices for specifying implementation strategies. They stress the importance of naming the strategy and using language that's consistent with the existing literature, helps to ensure clarity and allows for when you do this kind of naming and specification, it allows for comparisons across studies that are trying to look at the same strategy. Defining the strategy, it's always important to be clear about what, not just naming it, but what's in it, what are the active ingredients, and then more detail, like who's the actor, who's delivering the intervention, who's carrying it out. This could be a healthcare provider, it could be a patient navigator, the patients themselves or clients, or some other individuals. What are they actually doing? What's the action, and what's the action target? What or who is being targeted by the strategy? Several other things here, including, some of the implementation outcomes that you'd expect to be impacted by the strategy and, how they're going to be measured. But the better we specify these implementation strategies, the easier it is to measure them with accuracy and to measure their implementation as well and to compare their effectiveness across different studies and settings. So yeah, just to summarize here, then implementation research encompasses both implementation outcomes and health outcomes, in my opinion. While health outcomes are important, the implementation outcomes give us more insight into whether and how an intervention is being adopted, taken up, and sustained. And this is at the heart of implementation science. Um, it's important that implementation outcomes reflect the actual target of the implementation strategy, whether that's the coverage of an intervention or changes in provider practices or behaviors. And without measurement and assessment of implementation outcomes, it becomes harder and sometimes impossible to grasp the how and why behind the intervention's impact or lack thereof. So, for example, if we don't see an effect that's that we expect to see on health outcomes, then you need to ask questions like, well, why wasn't there an effect? Why was the effect really only modest or much less than we would have expected? This could be related to the implementation of the intervention, or the strategy, or and not necessarily the intervention itself. It could be that the intervention itself is not effective in this setting for one reason or another, but you need to be able to distinguish between these scenarios. Um, and the choice of implementation outcomes is driven by several factors beyond the main implementation research question. And lastly, the definition and adequate specification of key details about the strategy, as we discussed, is crucial for advancing the field from here. So I just want to go through a few examples now, just to make it a little more concrete. These are examples from some of our research within the IDEA cohort collaboration, which I'll just say a little bit about here for background. IDEA stands for the International Epidemiologic Databases to evaluate AIDS. It's a global network of regional cohorts. NA Accord is one of those cohorts for North America, but we have regional cohorts from 6 other regions around the world. It's more than 700 HIV clinics across 44 different countries, and it tracks data on about 2.5 million and growing patients who've enrolled in HIV care at those clinics since 2004. It covers every continent except Europe, and the data sets that come from each region are sort of merged and harmonized to answer many research questions related to HIV care delivery and HIV care related outcomes. We also have working groups that help focus some of the research, and these groups have experts in the different areas that are represented in the working groups. They raise and address some of the relevant questions related to their specific content area. But the main point I want to impart here is that the IDEA infrastructure really serves as a powerful platform for conducting observational research, including implementation research. And it generates a lot of evidence aimed at improving HIV care outcomes around the world. So this setting is basically the research setting that I want to provide some examples from. The first thing is the IDEA site assessment. I want to present that because it is a rich source of data on implementation outcomes for us. It has really, so I'll give you a sense of what it is. It has really 4 main objectives that are aimed at documenting details about HIV care and treatment service delivery across our participating sites, the 700 sites I mentioned. It captures things that are not reflected in the patient data that we get, right? All the individual level data that we get on patients really don't tell you anything about, like, well, what kind of adherence support services are there for clients? What kind of what kind of service delivery strategies are being used across different sites to help support patients or improve their outcomes. What's the comprehensiveness of care? So to get at some of this stuff, we routinely do site assessments to document these other things that are really not reflected in the cohort data itself, the attributes of the service delivery features. We also delve into specific topics related to HIV care that can maybe help fill some gaps in the literature. And we use the site assessment to get preliminary data to support future projects, so we can start asking new research questions. And lastly, the data collected is used to inform the development of implementation of future, more detailed site assessments and also intervention studies. It can help us identify the gaps in HIV services that are existing at the sites and across countries and regions, and identify the areas where interventions might be able to help make the most impact. The site assessment survey has been conducted multiple times over the years, so this also allows us to look at trends over time. We've had really high response rates. And for those that want to know more, we recently did publish a paper that talks about how the process we use to design and implement it. So I present this again just so you can get a sense of where some of the implementation outcome data come from in IDEA. It's evolved a lot from the different versions of site assessment, and we call it site assessment 1.0 and site assessment 2.0, et cetera, to represent the different iterations. We've moved from different. We've designed the survey in different ways. And the most recent example, we did something that was more investigator driven to support to identify what data we would collect. There's some things that we collect consistently across every version, and then there are other things we add to try and adjust timely, mostly implementation related questions. And it's been a pretty good source of scientific productivity in the IDEA network. To give you a sense of everything that's in there, it's a list of like 16 different areas, and in the bold font here, you can see the different things that have kind of been on each site assessment consistently over time, and the unbolded things are things that were added to the most recent site assessment. We don't necessarily have that going back historically. And this is an example of the kinds of investigator-driven content that we specifically, while we were designing the questionnaire for this latest round, we asked IDEA investigators to submit their ideas in the form of concept proposals, detailing the research questions and the types of data elements that they would need in order to address them. And then we as a working group worked to add that content to the site assessment. This gives you a sense of the kinds of things that were considered topical at the time. And I think I mentioned there's an electronic version of the site assessment and a paper version. Electronic version is REDCap, but not everyone has access to REDCap at the time they're completing the survey. So we also share a PDF version. But I include just a snapshot of a couple pages here to give you a sense of the level of detail that we collect and the types of questions we ask. The next few examples will just be a little bit more specific, so you can get a sense of how we've used these data to do implementation research in IDEA. The first one is about what is the uptake of doing screening and treatment for mental health disorders in HIV care programs is an evidence-based strategy or to improve mental health outcomes and possibly HIV outcomes as well. And so this is a study that was focused on getting this kind of information from low and middle income countries in the IDEA network. Harking back to the to the issue about characterizing the aspects of the intervention and specifying it. We tried to adhere a little bit to that framework, and I include the table here from the Proctor study I mentioned earlier, and a line here, questions from the site assessment around mental health that we use. So we didn't align it perfectly, but we asked questions like, do you screen for mental health or for depression? Is there a written protocol? When do you do the screening? Who does the screening, things like that. And here you can get a sense of the output of some of these data collections. We found, thinking about integration and management of mental health and also substance use disorders at 95 treatment programs that received this questionnaire. We broke it down also by World Bank income designation, and just focusing on the depression part here. Across all the sites, we found that 70% offered some sort of on-site services for depression management, and 18% offered those services, but they were off-site. But 12 didn't have any services related to depression. And when we broke it out by income designation, we could see that 89% of the sites in upper middle income countries offered on-site services compared to 51% in lower middle income countries. And so, the takeaways here include, that significant gaps existed in the management of mental health and substance use disorders in HIV care settings, particularly in rural settings, and that it's important to I identify and evaluate optimal implementation strategies to scale these in HIV care around the world. I mentioned that we do these surveys over time, and so when things are asked in a repeated way over time, we can ask questions like this: has availability of substance use related education, screening, and referral to treatment in routine HIV care delivery settings changed over time? And this is a map that just shows, the participation of different regions, different countries, IDEA sites in different countries in multiple site assessments. So in the pink, you can see those places where there were sites participating in 2 rounds, 2014 and 2017, and then the blue and the light blue and the darker blue show those areas where we only had one site assessment. But to look at trends, obviously we need to be able to look at more than one data point for each site. But here you can see that over time, or actually, you can see how things have changed in the availability of these different services over time. So in substance use education, you can see that it was available at both time points in 76% of cases. In screening, it was available 54% of the time in both time points, and referral at 44%. And the orange bars are showing you, how things changed over time, where it wasn't available before but became available. And the worst ones is where it existed at the earlier point in time and went away. So kind of like a service, an evidence-based strategy that was part of a comprehensive care program was going away in some sites. Yeah, so taking away here that there have been increases in the proportion of sites offering substance use education, screening, and referral services, but that there are gaps that persist. Again, this can set the stage for future research studies and even intervention studies that are focused on implementation of these kinds of strategies. So this slide summarizes a paper that IDEA did on PrEP availability across 199 IDEA participating sites. over the time period 2014 to 2020. And so again, allowing us to focus on changes over time. Um, and here you can see in 2020, 81% of sites reported that PrEP was available either on site or by referral, but there was a significant variation by the IDEA region, and it was lowest in Central Africa and West Africa, for example, and highest in North America and East Africa at the sites, IDEA sites in these locations. Um, PrEP availability, though, we found was pretty importantly influenced by whether or not the drug was officially registered in the country. So we were able to do not as part of the site assessment, but additional data collection around context allowed us to take a look at whether or not this was an important factor. And what we found was that where PrEP was registered officially in the country, the availability was much higher, around 91%, compared to sites in countries where it wasn't registered, which is closer to 44%. And if you look at changes over time, you can see, the clear upward trend of PrEP availability at IDEA participating sites, from 47% in 2014 to 60% in 2017 and 76% in 2020, but still the substantial regional variation. Um, our team's also done a lot of work around treat all policy implementation at IDEA participating sites, which I wanted to share with you. Um, just by way of background, like over the years, WHO has put forward progressively expansive guidelines on when to start antiretroviral therapy in someone who's diagnosed with HIV, right? So early on, really only people would be eligible for HIV treatment according to WHO guidelines, which, by the way, most countries adopt if their CD4 count was suggestive of a very advanced disease. So, and then progressively over time, it became more expansive. So 350, then 500. And then by 2015, WHO guidelines clearly recommended everyone with HIV, regardless of their disease stage, is eligible for antiretroviral therapy and should begin it, within 7 days of a diagnosis, if possible. So, this was I think there are a lot of implementation related questions around this, and lots of considerations when framing the research questions. So with the very high rate, we had very high rates of loss to follow up after care enrollment in these situations, often because people would show up at a clinic and find out that they were not really eligible to start treatment at that point, and that they should just come back for CD4 monitoring. And when the guidelines expand like this, there's the potential for lots of outcome improvement. So, people who become newly eligible and can start treatment, as soon as the first time they show up at the clinic, as opposed to having to be monitored over time. So but while the other piece of the other consideration here is that while WHO now recommends immediate initiation of ART, sometimes, and while most countries adopt WHO treatment guidelines, sometimes the timing between when the guidelines come out and when the countries adopt the policies can be a lag. There's a lag there. But with these suboptimal care continuum outcomes prior to ART initiation, guideline expansion can improve outcomes, especially for these newly eligible people. But on the flip side, there's also the possibility that guideline expansion that results in many more people being eligible and starting treatment could negatively influence outcomes of people who are sick and maybe eligible under earlier guidelines. So you have to, this is like sort of the unintended, potentially negative consequences of guideline expansion, which we were, also wanted to be mindful of. But you can see in the map here that by 2017, this map is from WHO, most of the countries, but not all, around the world had implemented some kind of official national policy on treat all. But it's another question altogether, right? if it's started at the national level, there's a policy in place at the national level, um, you know, have individual care sites begun to actually implement the policy as part of their practice. So clearly, the IDEA site assessment is a good place to examine this kind of implementation research question, and we thought it was an important question, and added questions related to treat all implementation as part of the third IDEA site assessment in 2017. So we could say something about its implementation, and I'll just quickly summarize. A paper by Ellen Brazier published in JIS on this. But we found that by the end of 2017, 91% of sites in IDEA reported implementing treat-all policies. But we also saw that site implementation of treat-all site level implementation varied across IDEA regions. We found that 12% of sites located in countries that have not yet adopted treat-all were essentially implementing that have not yet adopted treat-all policies were implementing it anyway. And in countries where national treat-all policies did exist, approximately 4% of sites were still not implementing treat-all. It was still pretty good uptake. Among the sites that implemented treat-all, 37%, this is for more detailed questions that we asked, 37% said that they, on average, were starting people on treatment the same day that the HIV diagnosis is confirmed, or the day that they're enrolling in HIV care. And an additional 42% said that patients generally start within 2 weeks of confirming their HIV status. Among those sites that were not implemented, it was just interesting to compare. 15% reported that patients generally initiate ART on the day that they're confirmed as being eligible. We also saw a difference in the number of ART readiness counseling sessions that were being conducted in sites that were implementing treat-all compared to those that were not. So the WHO guidelines for treat-all policy, recommended that anyone enrolling in care should initiate treatment as soon as possible, ideally within 7 days of diagnosis. And to us, that meant that all those newly enrolling in HIV care should be starting ART rapidly. And that's what we would expect to see happen in our patient level data when treat-all policies are implemented. So it's one thing to say that treat-all policies are being implemented at the national level, and it's another thing to say that they're being implemented at the site level, like we just showed. But it's another question to see if these national policies actually translate into meaningful improvements in timely ART initiation after enrollment in care under these policies. And to address this question, we turn to the patient level data in 6 sub-Saharan African countries. Here we use the data on about 814,000 patients who were ART naive, enrolling in care during, before and shortly after treat-all policy implementation. And our outcome here was, did they start treatment within 30 days of enrollment? And we called that rapid ART initiation. And in this analysis, we also used regression discontinuity design so that we could say a little bit more about the causal effects of the policies on these outcomes. And this is just a crude analysis here, but you can see, under each of these successive guideline expansions, because I mentioned we went back to 2004 here, so all of the guideline expansions, you could see the proportion of patients coming through the door that were starting treatment within 30 days under each guideline. And so the biggest jump was with treat-all implementation, when an additional 26% of patients coming through started treatment within 30 days of enrollment. So about 82% of all patients at that time were starting treatment within 30 days. You can see how it varied by country and by some patient characteristics here. We also were able to sort of get some analogous data to the site assessment. 59% had started treatment on the same day of enrollment. 75% within 14 days of enrollment, and about 82% within 30 days of enrollment. And the slide I'm showing here is just kind of a graphical representation of the analysis, and you can see the different patterns of the different patterns of change that happened right after treat-all policy implementation in each of the different countries included in the analysis. So, a big jump in some settings right away after treat-all policy implementation, and then, sometimes gradual, sometimes continued rapid increases. And this speaks to like the sustainability, right? When you see continued trends after implementation in the right direction, it suggests it's a policy that was implemented that's going to be sustained with programmatic changes that are going to be sustainable. And we also looked at correlates of whether or not, who didn't initiate ART within 30 days under treat-all policies, and we were able to find some important trends that we thought were relevant for HIV care programs and national programs. So younger people and males were doing less well or less likely to start treatment rapidly under treat-all policies. But the good news is that even this outcome was getting, as we saw with the trends, getting better with time. We could also use these data to not just look at uptake of ART or the impact of the policies on treatment outcomes, but also on things like CD4 testing and viral load monitoring. We were worried that under these new guidelines that didn't require assessing clinical eligibility of patients anymore because it's treat all, that providers might not do, or national programs might not do CD4 testing, or they might do less CD4 testing because it's not needed to assess eligibility. Of course, it's needed for other reasons, but the concern was that there might be less CD4 testing. And I won't go into too much detail here, but we were able to break this out by age, right? We've got adults, adolescents, and children here. And on the top, we've got, high and middle income countries in green, and lower middle income countries in blue. And you can see the effects up here. We've got CD4 testing prior to ART initiation. You can see a significant drop off for adults and a downward trend. Similar for adolescents and children. And we were also looking at viral load monitoring. We sort of suspected and hoped that viral load monitoring would improve after treat-all policy implementation, and it did to some extent. But just to give you a sense of the ways that we're looking at using IeDEA data to look at the effects of implementation on health outcomes. And the last example I want to show is one related to Dolutegravir uptake. WHO recommended Dolutegravir as the preferred first-line regimen globally. After that recommendation came out, there was a safety signal, and many countries adopted policies that a safety signal around teratogenicity that adopted policies that really restricted the use of Dolutegravir in women of reproductive age. And this was a study by one of our Epi-PhD students, Matt Romo. He looked at trends in uptake of Dolutegravir over time by age and gender. And here you can see where WHO issues this statement on the safety signal. Later on, it was confirmed that the safety signal was not a real concern, and they reinstituted a recommendation of Dolutegravir for all. But by that time, you can see that women of reproductive age really had disparately low uptake of Dolutegravir compared to older women and men of different ages. We're continuing to do some of this work going forward just to understand, this is now the question of policy de-implementation. When you remove policies that were intended to restrict access to Dolutegravir based on the new information that the safety signal was not really concerning, those places that had more restrictive policies compared to less restrictive policies, even though they all de-implemented their policies, the ones that had more restrictive policies continue to have persistent disparities for dolutegravir uptake for women of reproductive age. So this is sort of raises questions and hopefully will help provide insights around policy de-implementation in HIV care programs. Um, so yeah, hopefully I've convinced you that the IDEA cohort collaboration offers a powerful platform for implementation research because primarily I think because it's embedded in routine service delivery settings around the world. And I think has provided and hopefully will provide a lot more opportunity to better understand implementation processes and their impact in real world contexts. We've been able to collect a lot of site level data that helps us gain these kinds of insights as well as contextual data I've hinted at. We're beginning to use quasi experimental methods to help us, infer causal inferences about the effects of different implementation approaches. And yeah, I mean, there are lots of opportunities here for implementation research going forward. And I'm just going to end with an example of how we have gotten in the past, like the IDEA research community and our stakeholders and partners in in this work, including ministries of health and WHO, to come together to begin to identify research priorities that IDEA and other networks of implementers with data to allow it to advance the answering of important research questions, implementation research questions that can help inform a better implementation of the proven strategies of ART and testing and prep and all these other great tools that we have access to. So I also leave you this slide with a couple of resources that some of the papers I mentioned. We have a resource kit on our website that talks about some of these concepts more as it relates to population health outcomes. And lastly, I just want to acknowledge all of the people involved in the cohort collaboration, the site assessment, our team on Central Africa IDEA, and our CFAR and our funders. I'll stop there and I'm happy to take any questions.
Thank you so much, Dennis. Looks like you have a question in the chat. I don't know if
Oh, sorry.
Bianca wants to come off and say it.
Yeah, hi. So this is great. It's always helpful to really see how all of this is getting applied to specific kind of questions and interventions. But I just sort of in general, as I've been learning more about outcomes and sort of struggling to kind of place where certain outcomes should be measured depending on the kind of study you're doing. So if you have a slightly more novel intervention to like promote uptake of an evidence-based intervention, but the intervention itself is actually a little bit more novel. Like, how do you think about the types of implementation science outcomes you're using or, testing for like a feasibility study versus a pilot study, or if you have more of a type 1 versus type 3 hybrid design? Like, do you have any like clearer way of sort of putting those into buckets, I guess, for when you should study which one?
I mean, I don't know that I have a clear way, but I mean, for me, I always step back and ask, like, what's the research question we're trying to answer? If it's a pilot and it's about feasibility, then you have a lot of implementation outcomes that are related to, the fact of implementation. Did it actually happen? And how well did it happen? If you're doing some kind of hybrid design or some kind of trial, you're concerned with both the outcomes of implementation, but also effectiveness of the strategy on influencing health outcomes. It's for me, then that becomes a time where you're thinking about the causal pathways between when a strategy is implemented and what then should happen next so that you get to the health outcomes that your intervention, your evidence-based intervention is supposed to affect. And it's a whole other set of things that you may be thinking about. But again, it's really the research question. It's a totally different kind of research question. So a totally different set of implementation outcomes. I'm not sure if that helps at all.
Yeah, no, that's helpful. I guess I wanted to just make sure that there wasn't sort of some standard guidance for if you're doing more of a feasibility study, XYZ or outcomes you definitely need to include versus, in a type 1 study or something like that. So, it's reasonable that it's dependent
Yeah,
on research.
no hard and fast guide. I tried to just give a sense of like considerations and what's available to you is another thing, right? That may really drive your choice, whether you can collect it. And I mean, one consideration I think that really helps is like at what level of what level is the implementation happening, and that kind of drives that might be reflected in the framework that you choose. So if it's a healthcare system level kind of intervention, you might have a different kind of implementation framework. Once you have a conceptual framework to work with, that's another great place to look for like what are the outcomes that I need to measure, because you've obviously chosen a framework that conceptually maps pretty well to what it is you're doing. From that should flow several potential outcomes. Ronald, see your hands up.
Yes, hi, Dr. Nash. Thanks so much. This was really impressive, and thanks a lot for shedding light on the implementation outcomes. I really have two questions. The first, of recent, I've been coming across a lot of literature trying to rally equitable implementation science, so sort of health equity in implementation science. What are your thoughts about having equity as a taxonomy of its own, among the implementation outcomes, just like we have acceptability, and then we have equity as a taxonomy of implementation outcomes. The second is, in your experience, de-implementation and implementation, which has been harder to achieve?
Well, I'll do the second one first. I think de-implementation is just a harder thing to do. We were looking at a situation where it just happened and no one, but I think a bigger problem is that lots of things that are being implemented that don't necessarily have an evidence base and we have with limited resources to implement everything that needs to be there. We have to make some hard choices, and I think it's been much harder to choose which strategies to de-implement than it has been to identify new strategies to try. Your first question about equity, I think it's a really important topic, not one that has been explicitly addressed by implementation science as well as it should be. But it is essential because we've seen time and time again that implementation of evidence-based strategies and interventions, they may not always create the disparities that are there, but they often can worsen them. And I believe it's a problem of implementation science to figure out how to implement policies, programs, strategies in ways that kind of do no harm, and ideally they reverse disparities that exist, and then that gets you out of equity in achieving implementation outcomes to more like to do that you actually have to flip it and prioritize people and populations and geographic areas that have the worst outcome rather than try to have equitable access to HIV testing. It needs to be it needs to be accessed. It needs to be available in ways that are not equitable across all populations, but at meeting the need where it's greatest. And that I think is another shift that we need to be making, especially in large scale public health programmatic implementation.
Hi, Dr. Nash. Thank you so much for your presentation. I had a quick question as I'm writing. I think this might be a function of just being an early career, but a lot of our work is doing pilot trials and design of implementation strategies. I wonder, as we're writing these grants, I'm personally getting very tired of writing my outcomes of feasibility, acceptability, and appropriateness, and wonder if reviewers also have that same fatigue, and if there's any sort of ideas you have around creativity, or if this is just pretty standard and we should just accept that and know that the more the different implementation outcomes are more achievable as we scale up this work.
Yeah, no, I'm with you. I don't have any great ideas except to say that don't overdo it. Do what I think the implementation outcome is there. You can choose so many different things, right? And sometimes I see a lot of studies that are just trying to measure everything and check every box on the framework, and sometimes that's appropriate, again, depending on the research question. But I would say, you know, parsimony where it's appropriate is a good rule of thumb, and measure what you need. As for different, I mean, those are pretty bread and butter things, and it's I can't think of a suite of implementation outcomes that you can look at instead for certain kinds of research questions. It always comes down to those being the drivers. One thing that's helped freshen it up for me is thinking about, and this relates to acceptability and I guess feasibility, is we sometimes use discrete choice experiments, which maybe you might have someone come in and talk about, to measure like patient or client preferences for the kinds of different attributes of interventions that you're considering implementing or that you're already implementing. You can do it at the provider level as well, and these are often important determinants of the feasibility of implementation, how well the strategy actually works, how much of it, how it's taken up. I think there's lots of opportunity to be creative in designing these discrete choice experiments, and then linking those back to the preferences, back to the classic implementation outcomes that I think it's going to be hard to get away from.
Gotcha. Thank you so much.
Thank you so much, Dennis, for the great talk today, and everyone for the engagement. We will see you all next week.
Thanks, everyone. Have a great evening.
Thank you.